Hi, my name is Odhrán Murray and I'm a consultant orthopaedic and spinal surgeon, currently working in Galway in the west coast of Ireland and previously working in Glasgow in the west of Scotland. And I'm here today to share my experience over the last 10 years or so of using virtual clinics. And I think this is an ideal opportunity during the current COVID situation when we're all being kind of forced to phone our patients instead of seeing them face to face, and hopefully going to utilise the experience that I've had over the last 10 years to help you build and improve your practice and how to introduce virtual clinics to help your patients. In addition to that, how to overcome the barriers that you will come across in trying to implement that. So back in 2008, we first redesigned our fracture clinics in the west coast of Scotland, and I moved on in 2016 to do my new patient spinal, a lot of my new patient spinal clinics on a virtual medium, and in 2018, late 2018, to see the nerve root block return patients back at clinic through the virtual medium as well. And just today, we've because of the COVID issues, I will be doing my first COVID consent clinic for restarting elective surgery tomorrow. So that's exciting. So I was able to use the experience I've had over the last 10 years, as well as the colleagues that I've made in the information technology unit to help set up that system. So why did we change from virtual fracture clinic face-to-face to a virtual system back in 2008, going forward to 2010? And it was a large change back then when most people were against the idea, and really it was to try and improve our service to our patients. We had a huge capacity demand mismatch, and we wanted to deliver a true consultant-led service so that every patient had input from a consultant and that they were reviewed rapidly from their emergency department presentation to the fracture clinic, and we wanted to get within the 72-hour window, which was the national guidance. In addition to that, we wanted to help improve our costs and to help the environment as well. So looking at the national guidelines, when I worked in the UK, that was the British Orthopaedic Association and the Fracture Clinic Service, and working now here in Ireland, that's the Irish Institute of Trauma and Orthopaedic Surgery. And they recommend that a new patient consultation lasts between 20 and 30 minutes on the elective side, and on the fracture side, it lasts between 10 and 20 minutes. And really in the fracture side, we were not able to deliver anywhere near this. We're on average in around 4 minutes per consultation, and it wasn't really enough time to, especially for the complex patients, to give them the quality of care that they required. And our clinics would frequently overrun. So over 10 years ago, started to present this data and publish this data, and presented it nationally at our national meeting and then internationally at the BMJ conference in Amsterdam, and also the American Academy conference in San Francisco, before going on to publish the data in peer-reviewed journal. So we started back in Glasgow for the virtual clinic, virtual fracture clinic, and that spread throughout the UK and Ireland as the time went on. As you can see from the map, not only has fracture clinic, virtual fracture clinic usage spread throughout the UK, but also Ireland and to some of the rest of Europe as well. We've even got interest from the east coast of North America, as well as units in Australia and New Zealand taking up the system as well. So it's spreading out. So what exactly is the virtual fracture clinic? Well, you can go onto this website, which is on screen now. That's set up by my colleagues in Glasgow, and it helps take you through what it is. And if you want to, as a clinician, develop your own virtual clinic, then you can use the tools within this to do so. There's also lots of leaflets for patients, and they're all free to share, so that you don't have to pay or anything for the service. So one of the leaflets on that is the fifth metacarpal fracture, which is a common fracture that we see, and so long as there's no rotational deficit, these patients can be safely discharged from the emergency department without ever having to come to the fracture clinic. And use of these type of leaflets, and there are others, can help reduce the attendance at our fracture clinics by around 40%. So they're very successful. So what actually happens at the virtual fracture clinic itself? Well, it usually happens in the first 40 minutes of the fracture clinic, where all new patients are referred to it. There are 4 key rules. The first rule is for someone to read out the history and explain what's happened to the patient. The second rule is for someone to drive the X-ray system, so we use PACS. The third rule is for someone to make a decision. That's usually, is always the consultant, but sometimes we use it as a teaching tool, and it can be our registrar that makes the decision, so long as the consultant is there behind them, verifying that decision, and make sure the patient gets the right treatment by the right person at the right time and goes to the right clinic. And then that information has to be recorded and uploaded onto our information systems. This is one such system, the Blue Spear, which is an off-the-shelf system which you can purchase to do this. But when I moved over to Ireland to set this up as well, we were unable to afford this. This was going to be £50,000 to implement. So I contacted our IT system, and they were able to produce our own system on a basis called Evolve. So actually it reduced the number of systems it required, and we've actually produced a very nice system which is very effective. And basically after the fracture clinic, one of the nurses or the physiotherapist then inputs the data into the system, and what happens is it generates a letter for both the, so then what happens is it generates a letter for both the general practitioner as well as the patient. So we've now set this up so that we can email this directly to the general practitioner, so that we do not have to dictate, we do not have to sign our letters, and we do not have to print and post them anymore. It's just sent directly to the general practitioner, which is instantaneous, and a copy is saved to our Evolve system for use in the next clinic. As well as that, a letter is also sent to the patient, and as well as the letter to the patient, they'll also perhaps get a leaflet on how to do the exercises for rehabilitation, for example. And there's usually a little URL link which takes them to a website to show them a video of what their injury is and what physiotherapy they require to do in the coming days to weeks. What's really important is to have a safety netting system so that we do not miss any patients, and patients don't fall through the net. So on all our leaflets and cards and all the material that we produce, we have the phone number. That phone number is manned between 10 and 12:30 every day by either a physiotherapist or a nurse. If out with these times, they can leave patients can leave an answer phone message. What's really important about this process is that it's recorded, so that the problem is recorded and the outcome of the consultation is recorded, and that's really powerful from a medical legal point of view. So one of the questions I often get asked is regarding litigation. So for my colleagues, it's usually a barrier to changing from face-to-face consultation, which we're all familiar with, to a virtual consultation. Everyone worries they're going to miss something because they're not directly examining the patient, and I just want to address that issue. So one of my colleagues in another hospital in Ireland wrote to the State Claims Agency for us to start this process, and the head of the State Claims Agency has written back and explained that we have legal cover for the doctors and the allied health professionals that are carrying out our virtual fracture clinic here. And in addition to that, that he was quite impressed with the supporting documentation that was provided. In addition, my colleagues in Glasgow wrote a paper which was published a couple of years back, looking at the legal aspects of virtual clinic, and they did so along with this gentleman whose name is David Stevenson. He's one of the lead QCs in Scotland, and he works for both the NHS and the defence side, and also on the prosecution side as well. So he's a very good legal mind in this, and he found that the virtual fracture clinic was actually a very robust model, and a more robust model than the face-to-face fracture clinic that we run previous to that. And the reason for that was that every patient had it was a consultant-led service, so that there was decision-making made by a consultant at each stage. We based all our decisions on the best available evidence, and we used protocols to drive that. And that was a much more robust system in addition. The time from the emergency department to the clinic was actually faster by doing it on the virtual system. And this is also true, and we'll see this later on in the talk, for the spine service as well. We're able to provide better time management for our patients. And the patients who really needed to be at clinic, we could spend much more time with them explaining what was going on, and give them the time that they needed to be seen at the clinic, instead of trying to rush through them to see patients that did not need to be at clinic. So moving on to the virtual spinal clinic. Back in 2015, when I started as a consultant, we were getting around 2,500 referrals per year, and that wasn't including the back pain. They were going to the community back pain service, and it wasn't including several other thousand that were going to the neurosurgery department. On average, that was 216 patients per month between 4 consultants, and there was clearly supply and demand capacity mismatch. On this graph, you'll see that the line at the top of the graph represents the increase in demand for our service, and the capacity was remaining static, as you can see by the bottom line, and there was quite a large discrepancy there. So we need to rethink different ways of working to try and meet that demand. So I looked at the flow through our service, and we had patients that were waiting a long time from GP to first appointment just to get an MRI scan, and then they went off, waited for their MRI scan, and then waited for the return appointment. So we felt that we could at least take this component out of the service, out of the system. So before implementing change, we wanted to see if we could predict which patients would require an MRI scan based solely on the GP letter. So over a 4-week period, we looked at the GP referral letters for 330 patients in our service, and predicted whether or not they would go on to require an MRI scan. We had a positive predictive value of 84%, which meant that where we thought they should get an MRI scan based solely on the GP letter, they actually did go on to have an MRI scan. So the reason it wasn't higher was because by the time patients got to the actual clinic, their leg radiculopathy had often settled and they did not require an MRI scan. This could be ascertained by a telephone call, and this number could have been higher if we had added in the telephone consultation to the GP letter. In terms of timing, for routine patients, the average time to their first new patient appointment was 125 days, and back following their MRI scan to their return appointment was 202 days. For the urgent patients, this whole process took 149 days. And for the urgent suspected cancer, this was 89 days from time of GP referral to their MRI scan to being told the news of whether or not they had cancer, which is, I'm sure you'll agree, is completely an unacceptable timeline. So using this information, we designed the virtual spinal clinic. So after initial vetting, around 70% of all GP referrals are deemed suitable for the virtual clinic. However, around 30% are not deemed suitable, and they may be people who perhaps speak a different language, or people who have learning difficulties, for example, or people who have complex cases that need to be seen on a face-to-face basis. We ran 3 clinics per week, and it's very important that you have the IT set up, the digital setup to back up your system. We had a phone consultation and an experienced decision maker, and for the first clinics that was consultant, and we'll explain that we went on to use allied health professionals later on. We utilised a system called Blue Spear, and all our patients were populated onto this before the clinic, and we could simply click on that, get the patient information, and go through the system. This is an example of a dummy patient called Demo Dolly, and we can simply click on the virtual fracture clinic module, and on that we can run the assessment, and we can also have pre-populated letters that we can send to our patients. So you simply click on the spinal site, the side, your suspected diagnosis, and how you contacted the patient before moving on to select which clinician made the call. And then we talk about the red flags and whether these were discussed, yes or no. And if there are red flags present, a drop-down box occurs, and you have to write in what the red flags are. We can then go on to state the imaging requested and anticipated follow-up, as well as the outcome of our consultation and the fact that we completed the MRI safety questionnaire. And we also can then document that we have given the cauda equina advice, and that the cauda equina advice leaflet gets sent to our patients. In addition to this, at the same time, I will request the MRI scan, and I will copy and paste the MRI scan request into the additional information section. And this produces a letter to the general practitioner without having to dictate, without having to type, and without having to then check and post that letter on to the general practitioner. When we moved to Ireland, we did not have the funding available to use the Blue Spear, which was going to cost us £50,000. So I approached the IT department here, and we made our own system. And you can see in this slide, it's a very similar system, and you simply click in the boxes and then you sign off at the bottom, which is your own digital signature, which means there's no more need for wet ink signatures. And the GP letter will get directly sent out from that electronic system to the GP by email. And if the patient has completed the adequate GDPR documentation at arrival to the clinic or beforehand, then we are able to send our letters out to the patient as well. If they haven't completed this, we simply post them out to the patient. What we found was that we actually were using very similar outcomes for the patients, around 5 or 6 outcomes, and therefore we were able to automate the letters that we sent to our patient. For example, if we requested an MRI scan based on the radiculopathic features they were describing, then we sent them the MRI request letter. If it was a scoliosis patient, we would send them out the whole spine X-ray request letter and order the whole spine X-ray. And for us, we were unable to do the whole spine X-ray in the same location. They had to go to the opposite side of the city, so it would mandate that they would have to have a second appointment. So this avoided that second appointment. There was also a letter for discharge, and if we were unable to contact the patient, we would send them a letter stating that, and we'd ask them to fill in an MRI safety questionnaire as well as a pain diagram to post back to us in a stamped addressed envelope. Once we received that, we could then request the MRI scan if felt necessary. There were occasions where they may only score for back pain and they had no red flags and no radiculopathy, in which case we would not ask for an MRI scan, and instead we'd either give them a call or else we would see them back face to face. If we were unable to contact patients on for a second time, then we would give them a further 2 weeks to get in contact and check we had their administration details correct. And if they did not get in contact within those 2 weeks, then they'd be discharged from the clinic. In a similar fashion, if they did not turn up for their MRI scan or whole spine X-ray, then they would be discharged from the clinic if they had no red flags present. This graph demonstrates the increase in our productivity in our unit after the introduction of the virtual fracture clinic in October 2016. You can see that in there was only 3 months in 2016, but already there was a 15% increase in our productivity, and that had gone up in 2017 in comparison to 2015 to 75%, and in 2018 to 97%. It slightly dipped down again in 2019 to 90%. This graph demonstrates the proportion of patients that were seen virtually at the spinal clinic in comparison to those who were seen face-to-face. On an average, we were seeing 42% of our patients, or new patients, via the virtual system. And that was despite the fact that the large majority of our patients were face-to-face clinics. And I'd just also like to point out that, once again, that the virtual system is not appropriate for everyone, so you still do need the face-to-face clinics for sure to see some new patients. And what we'd really predicted, what I had predicted would happen was that we would have a large surge in the number of return patients that we were going to see back And I was quite surprised to find out that actually it was only a moderate increase from around 10 to 20% per year comparison to the 2015 data. So we looked at 274 patients to look to see why we weren't getting this huge return rate. And it was actually because we're able to discharge patients directly from a virtual system quite routinely. And it was only a small proportion that were actually given return appointments. We're even able to add some directly to the surgical waiting list. But remember, we would see these patients at a preoperative assessment clinic for completion of the face-to-face history, as well as being able to do the clinical examination. Patients that were discharged may be patients that were able to discharge, maybe, for example, a 50-year-old lady with a previous history of breast cancer who presented with back pain. And for those patients, we would simply request a whole spine MRI urgently, and as soon as the result came back for that, we would contact the patient and let them know that there was no problems on the MRI scan, they didn't have cancer, and the patients were grateful, and we could refer them on, if required, for physiotherapy in the community, and they never needed to come to the clinic. They were discharged. In terms of our key performance indicators, we requested MRI scan less with the virtual system than with the face-to-face system. So 55% of patients got it in the virtual system, where previously we were requesting it in 72% of all our new patients. And this was one of the hurdles we had to overcome, was to convince the MRI department that we weren't going to be requesting a huge amount of MRI scans unnecessarily. The patient wait in the virtual spinal system was much quicker, but it was still unacceptable. So there's still a lot of work to improve that's required. Our productivity had improved. We were able to see 300% more patients per clinic. Our productivity had improved. We were able to see 3 times as many patients in the virtual system as we were in the traditional system per unit time. In terms of automation, the majority of the virtual spinal clinic patients gone through an automated system where we're able to just click on the computer systems and produce letters, not only to the GP, but also to the patient, as well as producing safety leaflets to the patient, such as the caudal equina advice sheet. In terms of cost, we're at least able to say that there was no increase in the cost between one system and the other, although we do believe we had large savings as well. Although we do believe we made some savings, but these were mitigated by the fact that the same people were still doing the same jobs. We're just able to see more patients per unit time. In terms of patient satisfaction, that was mixed. We surveyed our patients. They liked both systems. In the traditional model, they liked the face-to-face component. In the virtual system, they liked the fact that they were getting seen much quicker and more efficiently. In terms of standardization of care, not go for that one. In terms of patient satisfaction, we had mixed reviews with both systems. The major problem with both systems is the patient still had to wait an unacceptably long time. The virtual spinal clinic system allowed me to create questions for the data that I wished to capture so that I could present going forward for audit and research purposes. We're trying to get data from the old traditional system. It was a very difficult and time-consuming process. So hopefully we've shown that we increased our productivity, but there's a number of reasons why productivity could have increased over the years. And one of those is that we had some allied health professionals that were kind of coming and going, and we could never really pin down the exact number of that. So in order to help to get a bit more causation and to improve the science of what we were doing, we asked the University of Strathclyde Business School to help us with the project. And they were able to build a model of the traditional system as well as a model of the virtual spinal system, and they did so using what's called direct event simulation. They did so using what's called discrete event simulation, and the model that they used was, the software that they used was a software package called Simulate, which was developed at the university. And it's a complex mathematical and computer system which can look to build models, and it's used in the retail industry quite extensively, and we wanted to use it in the healthcare setting. And what we did is we built the traditional spinal clinic model, and we built the virtual model. And then we were able to validate those through what's called black box and white box validation. And this validation model here shows you the real system in the middle row, and in the bottom row it shows you the virtual spinal clinic simulation model. And that shows very close comparison of the numbers through both systems with 95% confidence intervals. So we're able to validate the system. So one of the recommendations from the team at the business school was that we change one of our face-to-face clinics to a virtual clinic per week, and by doing so that we would change the number of virtual patients seen virtually from 48% to 66%, which represented an increase of 31% in our capacity. They also suggested that we use allied health professionals such as extended scope physiotherapy practitioners, and that this would perhaps lead to a 64% cost reduction. However, I would say that this has to be offset by the fact that the physiotherapists may request more MRI scans, or that they discharge less patients. So we have to really look into those costs in detail. But one of the other recommendations was that we use a validated training program. So we took that on board, and we introduced more physiotherapists to the system, and we went through a validated training program, and that just happened before I left Glasgow. So hopefully that will show promising dividends in the years to come. Obviously, COVID has happened since then, so it's difficult to tell how that's progressing at the moment. So in addition, the university calculated the environmental impact by looking at the average journey of our patients to the clinic. They found that each patient emitted approximately 0.01 tons of carbon dioxide per visit. And if that was taken over the 2-year study period, that was equivalent of 30.8 tons of carbon dioxide, which was enough carbon dioxide saving to power 6 cars, 5.5 homes, or 4 million smartphones during the study period of 2 years. So I think the additional benefits during the current COVID scenario is that our patients are not allowed to travel unless it's for an emergency reason. So if we can do this over the phone, it's much, much better, obviously. Thankfully, I'm able to start elective surgery tomorrow, and I'm going to have my first COVID-19 virtual consent clinic tonight, and I'm going to phone my patients for tomorrow and once again go over the risks of elective surgery that we know about, and also discuss the fact that there are probably risks that we do not know about for patients undergoing elective surgery in the current situation. So this is again using our computer system here, which is called Evolve, and they're able to very quickly build this generic letter. You simply click on the date, how you contacted your patient, you electronically sign it off, and once you push submit, it gets saved onto the Evolve electronic system, and thereafter it is emailed to the general practitioner and either posted or emailed to the patient. So it's a very efficient system. In addition to that, during that telephone consultation, we can signpost our patients to useful websites such as the British Association of Spinal Surgery, where they'll find useful information not only on the procedure they're about to undergo in normal times, but also, for example, the risks associated with having a nerve root injection, for example, during the COVID times. There's also an information consent form for patients, which patients can read, and they can sign that consent form when they arrive on the morning of surgery. And this takes the pressure of having to read through that on the morning of their surgery. So I hope you've enjoyed today's talk. Hopefully you can use some of the data that was presented to persuade some of the people in your department or your managers to help overcome the barriers of setting up a virtual clinic. And hopefully through the last 10 years of experience that I've had, that you'll be able to be convinced that actually a virtual clinic is something that we can all do, and that benefits our patients. I would like to say that one of the key features is getting your IT system up and running before you start. either by buying something off the shelf or getting your own IT department on board and getting them to help produce that. You will run into several barriers as you start to do this, but hopefully through today's talk, show that these barriers are actually relatively easy to overcome. In addition to that, the question that comes up over and over and over again is around litigation, and I think it's probably important to contact your legal department to let them know about the system, to share the data, to share how sound and safe it is, and get your legal department to put in writing that they are happy to support you with the data that we presented today. Thank you for listening. Bye.